Great. Well, thank you. My name is Tony Calhoun. I'm also in Boston, right across. I started off right across the street from Bill. Actually, I started off at BI, but I've been at MGH with the Center for Transplantation Sciences since 2019. I have no disclosures other than that I don't currently work with the MGH clinical team. I'm there purely in a research capacity. So we're going to talk about a little bit about xenotransplant. What xenotransplant is it's the transplant of tissues and organs from one species to another. And what this attempts to solve is that transplant dilemma where we have more patients that require transplants than we actually have organs that are available to transplant. But with that, there's many immunological and physiological barriers that go along with it. And Norman Shumway commented on xenotransplant and said that, xenotransplant is the future and always will be. So he passed away in 2006, but Bart Griffith, who is a student of his, and we'll talk about him a little bit later, some of his work, said that, had he lived to actually see the advent of CRISPR and gene editing and cloning, that, he would have really softened his tone. And we'll look a little bit about why I think that's true. So we'll talk first about Keith Riemse. So he's considered kind of the father of modern xenotransplant. And just as a side note, so he was a Navy surgeon in the Korean War. And if you know the show MASH, the character Hawkeye is actually based on Keith Riemse. So in the 1960s, he was at Tulane University. And at that time, they had dialysis had been invented, but it wasn't widely available. The techniques of renal transplant were had also been shown, but the donor pool was very, very low, obviously, as you can imagine. So he'd been doing studies in animal studies, transplanting kidneys, and had up to 9-month survival with these animals. So what he ended up doing was he had a series of 6 patients, and he transplanted chimpanzee kidneys into these patients. And he had one of them that actually survived for 9 months, and she was actually a school teacher. She went back to work and had a relatively normal life. Before succumbing to what they described as acute electrolyte imbalance. They didn't go further into it. Kind of the most famous xenotransplant is baby Faye. So this was in 1984. This was Leonard Bailey was the surgeon. She suffered from hypoplastic left heart syndrome. And at that time, the Norwood procedure was about a 50% survival rate, and then they reported that further surgeries beyond that had very, very poor outcomes. So the possibility of survival was very, very low to begin with, and they hadn't really established neonatal heart transplant either. He also had been doing work in animal studies and had good results thus far. So they had about a 20-day survival of baboon to human heart transplant. And it was reported to have failed due to an antibody-mediated rejection combined with an ABO mismatch. But this had just a huge cultural response. Like, everybody in the world knew about this. This was very, very big at the time. And the lyrics at the top are from Paul Simon's song off of the album Graceland, and I know Taylor Swift has sung about a lot of pigs, but I don't think that she's sung about transplanting any of them. So you can see just like how big of a cultural event this was. Skipping forward a little bit, we're starting to think about, what is the ideal donor for xenotransplant, right? Are we going to continue with non-human primates that have a lot of issues, or are we going to look at a different animal species? And so in 2020, I'm sorry, in the year 2000, actually, Levi came out with a set of criteria. So in order to have the ideal donor species, we want to have anatomic and physiologic compatibility with humans. So both non-human primates and pigs can function anatomically and physiologically kind of very similar. There are certainly some differences, but they're both close enough where they would actually be reasonable candidates. You want no possibility of cross-species infection or zoonosis. You're never going to get this. But you want to get as close as possible. The thing with non-human primates, though, is that they're so close to us that they have a lot of these diseases that can be transmitted to us and are actually kind of some of the heavy hitters, right? So like we think about HIV, different types of hepatitis, Pigs still can obviously transmit disease to us, but the distance genetically between us kind of protects us a little bit. Resistant to human pathogens and disease process, we kind of just covered that. Inexpensive to breed, I can tell you that it is just immensely cheaper to breed pigs than it is to breed non-human primates. Short gestation with multiple live births, pigs win here hands down. So with pigs, you can have 10 to 14 piglets per litter. Their gestation period is about 4 months, and then 6 months after that, they're at a size where they could actually be transplanted into humans. So from conception to having an organ, it's about 10 months. With chimpanzees or with non-human primates, you're looking at multiple years. You're looking at 8, 9 years, and they're only having 1 or 2 offspring. And then no or minimal ethical controversy. You're never going to escape that in transplant, as we all know. But there can be an argument made that with pigs, we're slaughtering hundreds of millions of them for food every year in the U.S. So if we use a small portion of that to minimize human suffering and prolong human life, there's certainly a strong ethical argument there. But ultimately, there is no perfect animal. It doesn't exist. So what we've been able to do in the past 20 years or so with the advent of CRISPR, Cas9, and cloning is that we're able to take these pigs that are similar, but make them a little bit better. So how do we do that? So it's kind of a process of doing knockouts and then additions. And these knockouts, what we'll start off with, these are kind of like large carbohydrate molecules that sit on the in the endothelium and kind of say, look at me, I'm not you. And so the big targets that we're looking at is 1,3 alpha-gal, or just known as alpha-gal, Nu5GC, and then SDA, which is sometimes known as like beta-4-gal. And together they're known as the triple knockout, or TKO. There's other knockouts that we look at too. So there's growth hormone receptor. We want to reduce hypertrophy. You can knock out what's known as PERV, or porcine endogenous retrovirus. That's kind of to limit the zoonosis. And then on the other side of that, we're looking at what do we want to add in. So we took these things out that identify the pig as non-human, and we want to add in things that then down-regulate the immune system. So we want to decrease complement. We want to decrease coagulation. So we're adding thrombomodulin, endothelial protein C receptor, tissue factor pathway inhibitor. Human von Willebrand's factor is a cool one because pigs have a slightly different von Willebrand's factor. So if you add in human von Willebrand's factor, you can actually kind of decrease coagulation that way too. We want to reduce cell-mediated immunity, and then we want to decrease inflammation as well. So there's a whole slew of genes that can be added in or taken out. Nobody has completely defined like what is the perfect mix, and there's different schools of thought depending on who you talk to about what is appropriate, what is not. The one that we've kind of all decided needs to go is alpha-gal, and we'll talk about that in a little bit. So with xenotransplant rejection, you have kind of 3 stages, and they're broken up based off of kind of time, because all these different times, it's different parts of your immune system which are reacting to the organ. So with hyperacute rejection, we're talking about just minutes to hours. That's everything that's in your immune system before this is transplanted. The body doesn't have time to react to it, doesn't have time to build new antibodies. This is what we have circulating in us right now. Delayed xenograft rejection, so you start to get cellular and antibody-mediated rejection, that's kind of days to weeks, and then chronic rejection, I hope we get there, is months to years. So with hyperacute rejection, kind of like I said, you're looking at these preformed antibodies. So those are looking for those large carbohydrates we talked about. They're also looking for lipids and proteins that are active. And you also get complement activation. So you get the formation of the membrane attack complex, my favorite attack complex, that drills into the cell wall and then lyses it. All of these things are very damaging to the cells. And like I said, this happens, kind of in the first 1 to 4 hours. Sometimes, I'll show you later, as low as 10 minutes. It's pretty impressive. So we talk about alpha-gal. Alpha-gal, it's present in all mammals except for humans and old world monkeys. And it's actually the largest source of hyperacute rejection. This was shown by Dr. Cooper back in the 90s. It is our most abundant antibody that we have circulating in us right now. All of us, this is what we have the most is anti-alpha-gal. So 1% of your total IgG and about 4% of your total IgM circulating for everybody in this room right now. And that starts when we're neonates. So as soon as our gut starts to be colonized by gut bacteria, then we start to build up these antibodies to alpha-gal. And interestingly, it's kind of been shown to cause what's known as a meat allergy. You may have heard of that. It's actually been increasing in the U.S. There's been 110 cases reported between 2010 and 2022, and this little guy here is responsible for that. That's the Lone Star tick, and what it has in its saliva, it has this alpha-gal sugar, and so when it bites you, it injects that sugar. You develop a hypersensitivity reaction to it. Not everybody, but enough people that it's significant. And then you can actually develop a meat allergy. And so you're not able to have pork, you're not able to have beef. Anything that expresses this alpha-gal, you're not able to have. Revivicor has actually come out with a gal-safe pork and bacon products. So that's available now, but I hear the wait list is like 6 or 7 months. So if you're interested in more, I would check out Radiolab. They have a great 2-part series on alpha-gal. They do a really nice job. So this is hyperacute rejection. This is a wild type kidney, meaning that there are no gene edits whatsoever that was transplanted into a baboon, and this is rejection after 10 minutes. So 10 minutes and it's necrotic, it's dead, it's gone. This is showing what that looks like with a heart. Now you can see there's intestines around this heart. That's not normal. One of the things that we do is we do what's known as heterotopic heart transplant. We do a lot of that in our lab. And so what that means is that you can take these genetically modified hearts and implant them into the abdomen, and then you can watch the immunological process over time without it compromising the hemodynamics of the recipient. So the recipient still has their own heart that's beating along, and then they have a second heart in their abdomen, and then we can kind of watch that. We can do echoes, we can do biopsies, and we can look at it over time and see, are these gene edits really working? Is our immune suppression really working? But this one was a wild type, and you can see it got rejected very readily. As we go through, you can see normal cells, thrombus formation, interstitial hemorrhage, and then ultimately myocyte loss and fibrosis. So what can we do to prevent that? Kind of the ideas around preventing that are we want to prevent the antibodies, we want to prevent the complement. So coprevenom factor is kind of out of vogue now, but that was used for a while to reduce complement. Other drugs are used, plasmapheresis. Antibody sponge is a really cool one. So this one is unique to xenotransplant, and this is where, say you're transplanting a heart, you take a set of lungs out of that pig and you perfuse it with the recipient's blood. Now those lungs soak up the antibody and they soak up the complement before it gets to your heart that you want to do well. So we do those as well. Those are pretty cool. But ultimately what it comes down to is that, once that goes away, once you take away that antibody sponge and once the plasmapheresis is done, those antibodies can come back, that complement can come back and can still attack the organ. So ultimately what you need are gene edits. So this triple knockout, removing the carbohydrate targets, and then adding in those complement regulatory proteins is very important. Once you make it past that first 4 hours, you're looking at kind of days to weeks, and this is delayed xenograft rejection. This is both cellular and antibody mediated. And this gives your body time to react. So this is when your B cells are making new antibodies. This is when your macrophages are coming around and phagocytosing, and your antigen-presenting cells are presenting antigens. That's what they do. So this is a full immune response to the organ. And getting past that is kind of, there's similar ideas. We want to continue with gene edits, but there's actually something that's unique to Xeno really, is that we actually use co-stimulatory blockade as well. I mean, it's not entirely unique to Xeno, but it is very, very prominent in Xeno, I should say. So what co-stimulatory blockade does is that in order for B cells to go through different processes in order to have switching and making more antibodies, they actually have to have this two-signal process. So you have CD40, which talks to CD40 ligand on the T cell, and then you also have the MHC class II talking to the TCR on the T cell, and those together allow that B cell to proliferate and then build more antibodies. What we can do is we can actually take our own monoclonal antibodies that we then inject into these recipients that is anti-CD40. So it comes in there and kind of sits and prevents that second signal. And what happens is that it prevents class switching, and it prevents a lot of proliferation of those B cells. This also happens with antigen presenting cells as well. So you can actually kind of prevent helper T cells from ever becoming activated by preventing this co-stimulation. So going on to chronic rejection, it's kind of like the long term. Like I said, I hope that we get there. We've seen that in a few of our baboon studies that we actually get past this delayed xenograft rejection. But ultimately, it's not very well understood because very few recipients have gone to that point. A lot of what we've seen happens kind of the same as what happens in allos. We get proliferation of endothelial cells, vessel narrowing, ischemia. This is long-term rejection. So what we'll talk about next is kind of what I think everybody was hoping to hear about. There's been some clinical advancements in xenotransplant recently as well. So this gentleman was 57 years old. He's a cardiomyopathy patient, and he presents to University of Maryland in Baltimore. While he's there, he has his EF is 10%, and he gets to the point where he needs to go on VA ECMO. So he goes on VA ECMO for 6 weeks, and during this time, they're calling around to different facilities. They actually go to 6 facilities, both regional and national, to try to get this guy transplanted or to try and get him on a VAD. He's not going to be a candidate. So now he's on ECMO, and he has nowhere to go, right? So he's going to die on ECMO. Well, fortunately, he was kind of in the right place at the right time. So University of Maryland, Baltimore has an extensive xenotransplant program. Our program at MGH actually came from theirs that we split in 2018, kind of. So half of the people went to MGH and half of them stayed at Maryland. And they've actually shown the longest survival with both heterotopic and orthotopic transplant in a non-human primate model. So he's kind of in the right place at the right time. He's approved by the FDA for heart xenotransplant under expanded access. And his surgeon here, Bart Griffith, performed that surgery on January 7th, 2022. And the background is Muhammad Muaddin, who is the PI. He's kind of a powerhouse in xenotransplant. And so this patient got the first gene-edited pig heart to a human. This is a Revivicor 10-gene pig. So it had that triple knockout we talked about with the carbohydrates. It had growth hormone receptor knockout, and it had a slew of transgenes to downregulate complement, downregulate coagulation, and those that we talked about. So for immunosuppressives, he was on medications to decrease B cells, decrease T cells, and to decrease complement. He also had anti-CD40 monoclonal antibodies to do that co-stimulatory blockade. And so this is on the left, this is pre-transplant, and on the right, it's post-transplant. And so post-transplant, he was on VA ECMO for about 2 to 3 days. And then he was decannulated on day 4. Here's his hemodynamics on day 6. So he has a reasonable arterial blood pressure, PA pressure, and CVP, and he has a cardiac output at this point of 5 to 6 liters, which is impressive. So ultimately, he had life-supporting function for about 48 days. He did have a sudden deterioration on day 49 and had to be placed back on ECMO. And let's see if we can pull that up. There we go. So we're first going to look at day 19. This is day 19. This is his echo. You can see it's a well-functioning myocardium. He has a good ejection fraction. Looks very good. And then this is on day 49. You can see the thickened myocardium. And he's just not really, this is not a life-supporting heart, unfortunately. Now, what they suspect this was due to is this is kind of, they call it like an atypical antibody-mediated rejection. And it should be noted too that on day 20, they started to see porcine cytomegalovirus in the cell-free DNA samples. So they were kind of monitoring this the whole way through. Now that's not known to infect humans, but they're thinking that it was a combination of this antibody-mediated rejection that was then causing cell lysis, that was then showing the porcine cytomegalovirus in their cell-free DNA, that then it was kind of like an early signal, so to speak. So care ended up being withdrawn on day 60 because he was, at that point, the heart was non-recoverable. It should be also noted that they did do a second xenotransplant that had about 6 weeks survival. More recently, at MGH, we completed the first clinical kidney xenotransplant. This was Dr. Kawai and Dr. Elias. And this gentleman was a 62-year-old male. He had chronic kidney failure. He had been on dialysis for about 7 years, and then he was transplanted with a human kidney. That lasted about 5 years, and then he rejected at year 5. Now he's back on dialysis for about 4 years at that point, but his vascular access is failing. He's going back in every week to 2 weeks to actually clear clot out of his vascular access. So his outlook doesn't look very great at this point, except kind of having to be at the right place at the right time. Dr. Kawai is one of the other PIs, kind of in our adjacent labs. We use the same pigs, we share information. So Dr. Kawai is excellent. And so this patient received a 69 gene edited pig. So we went from 10 now to 69. Now this had 10 of those gene edits that we talked about before, and then 59 to take away porcine endogenous retrovirus. So that was kind of anti-zoonosis, is kind of like 59 of those edits, but 10 of them are only acting on the immune system itself. So immediately it pinked up and made urine. And on April 3rd, he was discharged home just over 2 weeks later. So his creatinine was 1.5, and he's remained mainly outpatient at this time. It's really incredible. And so this is a quote from him, and he says, this moment, leaving the hospital today with one of the cleanest bills of health I've had in a long time is one I've wished would come for many years. And I can tell you, in the laboratory environment, we have success with kidney transplant up to 3 years. So I have the greatest hope for him. I really hope that he does well. So it should also be noted that there was a second gene-edited kidney to human transplant. This happened at NYU Langone on April 12th, and that was combined with a durable VAD. That is a single gene edit pig, so that was just a gal knockout. And you can kind of see there's not a consensus yet as far as like what is necessary and what is sufficient. But we're at a really exciting time, and we're doing really fascinating stuff. And I think that we're on the kind of the precipice of a new era in transplantation. So I'd like to thank Dr. Pearson, Dr. Cooper, and all the CTS team, including Spider-Man and Batman.
Wow, that was all three impressive talks. It's amazing what we can already do and what we're heading to. And then I saw some impressive things, and good thing PowerPoint doesn't have an olfactory because that heart really looked bad and must have been a real bad smell. These papers are now open for discussion, so I already see Richard, who probably has many questions. We have no mic. Thank you. We have the mic.
Thank you. Yeah, got it. I have got loads of questions, but I'm going to give somebody else a chance to do that. But what I wanted to say is, on the online chat at the moment, everybody's going absolutely mad saying that is fantastic. And I have to say, that is an awesome set of talks. The fact we've gone from that basic science element through to actually doing something in the patients is incredible. And to see the skills, aside from just running a pump, that Perfusionist is getting involved in is absolutely fantastic. So, I wanted to say a huge, huge thank you. Obviously, I invited you here because I wanted to listen to it because it's close to what I do. But I hope everybody else has really kind of enjoyed seeing what happens when you get people who know what they're doing and actually do the research, and how powerful you can then make that message. It's fabulous. I will ask one question, and it's the case of, where do you think we're going to go with this in the future? How far do you think we can push it reasonably within the next few years?
Yeah, so as far as xenotransplant, like I said, I think we're kind of on the precipice of really seeing some exciting results. So I don't necessarily think that xeno is going to replace allotransplant, but there is an argument to be made that it could be an alternative, right? For people that are not going to receive a human heart, or are not going to receive other definitive care, or aren't a good candidate for the dialysis like we saw. Like I said, I don't necessarily believe that it will completely replace allotransplant, but I think that it's a good supplemental, if that's fair.
No, please. I think mitochondria definitely has some role to play. It really seems to help and perk up all kinds of tissues. It's not just being trialed in hearts, and it's all over the place: liver, kidney, all of this. So I think there's definitely something behind that, and I think because it's autologous, it's a pretty easy get. So hopefully we'll see a lot more of that work coming too.
I mean, I think once we get off the ground, we'll be expanding our donor pool for the pediatric patient population. It's just going to take us a while to get there and do it in a sterile and appropriate fashion. But there are a lot of donors that we can't harvest, so I'm hoping that this will get us where we need to go.
I have a couple of questions from the online chat. This one is for Tristan. How did you integrate the defoamer into your circuit? Like, people want to know the technicalities.
Like, we literally broke open the oxygenator and took out the inside, that's the defoamer content, and then placed it around where the base of the venous reservoir was, and it worked.
And how long do you keep a heart on the OCS?
So OCS typically is less than 6 hours as well. They have a number of other devices that they've developed. So last week, actually, we did our first liver in a box. Mm-hmm. So the reason that we did that one was because we had a Fontan patient who was getting a heart, and they did them in series instead of sequentially. And they weren't sure how that transplant was going to go. And so they kept the liver on an OCS device getting perfused as well. And then once the heart transplant was successful, they took the liver off the box and put it in. So it depends on the organ. They also have lung and they have kidney as well. But the longest we've done it was, I think, 7 hours. But, the longer we can do it, the better.
And this one is for Bill. Do you think it would be possible to expand the mitochondrial transplants into a cardioplegia hotshot, or something that we could use for on bypass?
Yeah, so that actually already has happened. That's part of where that isolation and delivery protocol came from, looking to use it in ischemic event style. Not just DCD was an easy follow-up because there's a created ischemia and there's a very measurable kind of easy controlled situation. The ischemic event stuff, you'd have to kind of do it a little more adaptable because you don't know when those are going to happen necessarily. But it's already being looked at, yeah. And it's not, again, not just for hearts, but all over the body. Yeah, most certainly. Cath lab, we've done it in the OR. So yes, it is probably going to be an available technique to people, especially since, acquiring mitochondria and getting it to the point of delivery has become a little bit easier, right? Before, it would have been a 2-hour plus process when you realized, oh, wait, I want to add mitochondria to the situation. And so as that process becomes a little bit more refined and better, it would become something that's way more readily available kind of in the moment situation.
Keith?
Yeah, Keith Atwell, University of Tennessee. Great talk. Thank you very much for that. Question for Tiffany and Bill. On your donor organizations, or have you both ever thought about adding milrinone as a part of your study? Low dose for OCS and the mitochondrial study.
So that one's easy for us. In this study, we did not need to. Yeah, we didn't have to add anything else to it, and we wanted to really kind of control it down. I'm sure further studies down the line could include, other additives or other strategies to change, but this was trying to stay pretty tight to what we actually do clinically.
Yeah, we don't like milrinone either, so we didn't use it for our sample population too.
If I could just, one of the things I didn't talk about is we actually do a lot of ex vivo heart perfusions. And in ours, we do these pig hearts versus human blood. And in our protocol, we actually we use epi, and then we supplement with milrinone as well.
Richard Melker, Children's Hospital, Philadelphia. Tristan, Bill, Tony, phenomenal talks. I love hearing all about this, and I know our audience loves to hear it, and I'm sure people online are like flipping over top, looking at what you guys are presenting and really enjoying it. One quick question for you, Bill, if you don't mind. Long-term effects of your injection of mitochondria. Are you seeing positive effects as time has gone on with these patients? The reason I bring this up is at CHOP, we, I think, collaborative approach with looking at single ventricles and injecting mitochondria. And I'm pretty sure, I believe that there weren't as good of long-term effects with those patients as they were hoping. I didn't know if with your latest research, what your long-term effects have been showing.
Yeah, so they were obviously once we put a heart in a box, we're kind of on a limited timeline. But tissue samples from other things have shown that those actual transplanted mitochondria are still viable 30 days out, and that they are still being active. And as this gets better, some of that stuff that we did early on, being direct inject and everything, there were still too many variables to say, oh wait, we did that the best way. And as this progresses, I think the results have gotten better and better. Some of it is to just get through that immediate acute ischemia and get them in there and get the heart functioning and reconditioned again. And so obviously long-term effects would have to be really looked at further.
Okay, I think.
Great talks, all speakers. I'm Isaac from Johns Hopkins. So I have a comment. I want to listen your feedback on that comment, number one. Number two, I have one question that has 5 subdivisions for Kristen. Okay. Tristan, I have a question, but it has 5 divisions. I will repeat that question. So first, my question is, can you hear me?
Yeah.
Okay. This is called as a low frequent, highly sensitive procedures. When we start ABO incompatible transplants like 10 years back, yearly maybe 2-3 cases we do. If you have a team of 6 members, maybe a couple of them will get the exposure. Some people won't even get the exposure for years together sometimes. So that makes us to do some errors and compromise the patient safety. So my question to you, the future is going this direction. You talked about the transmedics, xenotransplant, and mitochondria. We won't rule out. We will do it really in the near future. So my question is, how we can educate equally competent our team members when you get the exposure to this type of highly sensitive and low frequent procedures. So this is my comment. I want to listen your feedback. Question for Tristan. Several years back, 10, 15 years back, some part of the world, cardiac surgeons felt continuous coronary perfusion is better than hypothermic myocardial protection. But 3 to 5 years results that shows it's not. Of course, you are giving the blood transfusion or blood circulation or flow to the heart, but which is not better than a hypothermic myocardial protection. So back to transmedics. Of course, we are flowing the heart with normothermic blood. The fluid dynamics plays a huge role when we talk about the hemodynamics of the body or the myocardial or the heart muscle. So my question is, we are in the very preliminary stage in pediatric population. Maybe few centers in the country or in the world, they tried the transmedics. How challenging it is to maintain a blood gas, lactate, and all those things. That is question number one. Question number two, do you believe that as of now, the safe ischemic tolerance is 4 hours for the heart transplant? Do you think the transmedics era in the future would definitely increase the transplant threshold from 4 to whatever the hours? Number three, can we use transmedics for the ABO incompatible transplants or highly sensitized transplants? You want me to repeat the 3 questions to you?
Okay. Am I on here? Yeah. Okay, good. Okay, so question number 1 is
How challenge it is to maintain the blood gas and lactate levels.
So that's actually not that challenging for a couple of reasons. One is once it's on, so I'll start and break it down. Once it's on the device, unless there's an interruption in flow or you're not doing something correctly, the lactates really stay down on the OCS. And we showed in our little baby pig lab that that's also the case as well. I'm thinking about your question about like the continuous blood perfusion. I think that's mostly just to limit the ischemic time.
Mm-hmm.
I don't know how long out we're going to be able to push them. And I don't know even, I mean, this was a technique that we tried on our pediatric patients. I know our adult side does it pretty regularly and have really good results with the postoperative function. So I think that's one of the reasons why we considered it in our pediatric population. Obviously, we'd need to develop our own system and see if that was maybe the best practice once we have something for our smaller pediatric patients as well. Did I miss your third question?
Yeah. Uh-huh.
What is that?
The third question is ABO incompatible and highly sensitized.
Oh, yes. Yes, I think you could probably do that too. It doesn't matter because it's just the method of transporting the heart and then when you get it back. But I do want to comment about your how do you stay competent when you have these really challenging cases. I don't know why, but for some reason, I'm the only person that gets called to do the ABOI compatible by chance, right? Like I just happen to be on call when they happen. But they're really tough cases, Dawn can tell you. They take so much volume. You have to do all the calculations. You have to work really closely with the blood bank to do those. And we've tried to get some of our younger staff in to watch how it's done. And I think you just have to have people take time when they can to be able to look at it. But it's very challenging. We have the same problem with our ECMO transport program because we only get those a handful of times a year and you need somebody out in the field who can really troubleshoot and fly on the second. And sometimes it takes some experience to get there. So I think it's a combination of education and mentorship at the same time.
And you mentioned 300 to 700 for all the patients, the transmedics flow. How did you get that number?
So 700 is Transmedics number for their adult-sized patients. Like I said, we wanted to make sure we were flowing enough, and I don't think we found what the sweet spot is depending on the size of the heart. We're going to have to develop a protocol around that as well. Great question.
Thank you. And I made a comment about how to educate our team members when we do this type of highly challenging, low frequent and highly sensitive patients.
Yeah, we use a very similar strategy. We make sure we drag somebody else in. Hopefully it's a junior person who hasn't seen these things and really get them the exposure to it, and then increasing that frequency. Hopefully, if these take off, we'll have more of them. They'll be slightly more frequent. Again, we're not talking anything but we do that for all of our complex cases. We try to, this goes back to the staffing model we try to have somebody else around, and we're about to go to 6 ORs. So it's like, all right, how many people do you have around, right? So do you have one person floating for 6 perfusionists, or should you have 2, right? But when that extra person is around, we try to bring them in to show them at least the more complex portions of it, and we try to do that pretty often. So I think that's the only way to really approach that.
Yeah, and I think the other thing that's important from a mentorship perspective is that, I'm perfusion nerd, so I get really excited about doing an off-label case or trying to do it. And when that excitement is effusive and it boils over onto the junior staff so that they want to come in and they want to do the cases too. Like anytime we have a neonate, I'm the first person to get excited about it and hope to do it. So I've seen our younger staff where at first they were scared. They're like, no, I want to do it too. So it's kind of a mentorship challenge.
And I'm not sure on the time with the OCS specifically. There's another device. I'm not sure if they have FDA approval yet or not, from XVivo, the XVivo Heart Box, which is coming out soon. And they've shown 24 hours. So there's a paper that actually came out in 2016 where they showed that they would perfuse pig hearts for 24 hours on this device, and they would implant them into pigs, and then they just perked right up. No defibrillation, minimal inotrope support, came off bypass, no issues. I don't think that they've replicated that in humans yet, but the possibility is there for very long perfusion times.
Thanks again. Great talks.
Thank you. We have more questions. We have more time.
Chad Murphy, St. Elizabeth from Kentucky. Question for Bill with the mitochondria. What is the time frame it takes from extraction to implantation, as well as do you have any resources for storage?
We haven't done any storage stuff because one of the primary focuses was the immediate transplantation of it. One of the keys was the isolation and getting it pretty immediate available. Extraction obviously doesn't take, you're taking a chunk of tissue, so that's a pretty quick get. And then the purification is down to 30 minutes. It's actually almost ready just in time for when the heart is loaded onto the system and being reperfused for 10, 15 minutes already. So it kind of is lining up pretty nicely. And again, the goals would be to reduce that as far as you can so that you could very quickly acquire tissue and mitochondria and then quickly inject it. So it's really pretty quick. I haven't heard about any of the storage function of it, but I'm sure you could probably freeze it down and hold it in some kind of deeper storage.
Thank you.
Yeah.
All right. So I'm back up here, and I want to talk real quick about what if there's an alternative with ABO-incompatible heart transplants. I mean, Tristan, you and I, we have something more in common than we thought, I've had the great fortune of being part of a lot of these cases, along with my colleagues. I mean, we just seem like we're doing more and more of these. But even 5, 10, 15 kilo patients, and you're doing 3 times exchange transfusion. I'm not sure how many of you all have done that, but it's not fun. It's not fun. There's a lot of volume and there's a lot going on, and it's not what you do every day. So what if there was an alternative to that? All right. And would you like to have that alternative in the United States?
Richard, this one's for you.
Yes, it is, Richard. Richard Isaac, it is. So Richard Isaac and Alex and Great Ormond Street have done some great work over the past, how many years now? 10, going over a decade. The true benefit of being outside the United States is to be able to use non-FDA approved devices and really be there for our patient. It's something that Richard and I have discussed for the past 3 to 4 years, and trying to find a FDA-approved filter, more specifically called the column, to allow us to do ABO-incompatible heart transplants here in the United States without having to do a 3 times exchange transfusion. It's obviously a lot better for your patients, and doesn't put all the stress on the blood banks that we do with all these cases. So that being said, it would be great after this forum to discuss that further and possibly develop a plan on handling these types of patients, this patient population, and maybe come together as a group to find a solution to this problem in the United States and allow this for our patients.
Okay, we have time for one more short question.
All right, we have a question from the online crowd here. Will autogenic transplants be possible with 3D printing in the future? And how do you guys feel about 3D tissue?
I think so. A good friend of mine actually is working on that at Revivicor. So he does. He's a cool guy. He's a cardiac surgeon from Germany. He was a rock star before. He's just rad, really cool dude. Anyways, so what he's doing right now is he's working on pig lungs, where he's doing kind of decell recell technology. So kind of takes the lung scaffolding, kind of strips all the cells away, and then rebuilds on top of that. I can't really speak to like where he's at with his research, but they're certainly working on it. There's really, really cool stuff out there.
Thank you.
That's it. Thank you. Well, thanks to, oh, did you want to? Okay. Thanks to our excellent speakers and the many questions. This was the easiest moderating job I've ever had. So thank you very much for our excellent speakers. Round of applause.